Next one is fine.
Good afternoon. I think we have a quorum, so we'll get started. Thank you all for being here. It's a true treat that we are able to invite one of our own medical students to present formally at our grand round. So I'm Andy Schumann. I am one of the co-directors of the program in clinical ethics along with Christian Verkler. And this is really a privilege. So Kunal Bailoor is one of our third-year medical students. And as part of the ethics path of excellence, he's been intimately involved in how we have framed our policy at an institutional level. So over the last year or so, our institution has redefined advanced care planning at University of Michigan. And the advantage of doing so is that we are able to intertwine some of the real-life dilemmas that arise in clinical ethics consultation, along with basic clinical practice, along with the law, as well as how we as an institution think about what advanced care planning actually means. So over the next 45 minutes or so, Kunal is going to give you a little bit of a background in terms of where we were and what the law allows us to do and what it doesn't allow us to do, and how, as a result, we've taken our policies in a way to be thoughtful and recognize some things that perhaps in the past haven't been considered as robustly as we think they should. This presentation is meant to be interactive, so please feel free as soon as he finishes to open it up for discussion, and we're going to frame this with a case which should help put things into perspective as well. So without further ado, Kunal.
Thank you, Dr. Sherman. Can everyone hear me okay? Never mind. Can everyone hear me all right? Great. So my name is Kunal. I'm a third-year medical student here at the University of Michigan. And I wanted to give a brief talk today about the advanced directive policy that we've crafted here with the help of the entire ethics committee, And I wanted to frame it in a larger context, as Dr. Schumann mentioned, of the philosophy of advanced directives, the bioethical principles, and of course how that intertwines with law especially. And I wanted to start with a case that I think illustrates the importance of a broad approach to advanced directives and considering multiple valid forms of advanced care planning. So this case, patient JG is a middle-aged man with severe dementia, chronic dysphagia, and aspiration. Multiple attempts have been made to place a feeding tube. Unfortunately, the patient continues to pull it out. Psychiatry was consulted, and they determined that the patient did not have medical decision-making capacity. The patient himself does not have a durable power of attorney for healthcare, or DPOA-HC, or a living will stating his wishes or what he would have wanted in this kind of situation. He does have 3 adult children, and one is in the process of seeking guardianship to better be able to make decisions on his behalf. What we know about him from kind of past review is that he's an infrequent utilizer of the healthcare system and historically has disregarded medical advice. I wanted to start with this case because I think it illustrates a common finding, especially in clinical ethics consultation, of patients who require dynamic conversations around end-of-life care, but who oftentimes don't have durable power of attorney documents or sometimes require additional support. So, a brief outline, and feel free to interrupt me with questions or comments at any point in this talk. So I'd like to start with briefly talking about the philosophical basis of advanced care planning and kind of the bioethics behind it. I'd like to touch briefly on Michigan state law regarding advanced care planning. There is significant state-to-state variability in laws regarding advanced care directives, and what is considered legally valid in one state can often be very different from what is considered legally valid in other states. I'd like to touch on kind of written advance directives, so what we classically think of when we say advanced directives and advanced care planning, and acknowledge, of course, that these are very powerful tools, but they too can have their shortcomings. I'd like to talk a little bit about the new policy, and especially our consideration of documented interactions as a potentially new form of advanced care advanced directive. And finally, some consideration for practice at the University of Michigan given these updates to the policy. And I'd like to conclude with some ethical and legal questions just for consideration and discussion regarding these changes. So I'd like to start with a quote by Socrates and kind of summing up the philosophical debate at heart here. And Socrates had a deep mistrust of the written word. As many of you know, we only know of his thought and his teachings through his disciples. And he once said that writing is very much like painting. And what he meant by that was that when you have the written word, like a painting, it gives you a static picture. And no matter how detailed, when you'd want to try and get extra clarification, ultimately you cannot. And I think I wanted to start that out because I think that kind of frames the philosophical question that we want to talk about here today. A little bit more about the bioethics, the more practical side of advanced care planning. So why do we have advanced care planning as an institution, as a policy? Ultimately, it's about respecting patient autonomy even after they lose decision-making capacity. We believe that patients should have a right to determine what happens to their bodies and what happens to their persons, even if in the moment they lack the capacity to determine, to make that decision for themselves. Oftentimes, what this means in practice is the involvement of a surrogate decision maker. And oftentimes, these surrogate decision makers are close family members, friends, someone who knows the patient intimately. And the reason that we often look to these types of people is because we believe that surrogate decision makers should use what we call the substituted judgment standard. Essentially, that they should be making the decision that the patient would have made had they been in the situation and had they retained full capacity. Now, I think there's an important point to be made here, again, on the practical side of things, and that is, while we do hold to the substituted judgment standard, we can't expect surrogates to come in and with a whole host of conflicting emotions and interests, immediately understand what the substituted judgment standard is and how to properly make a decision. And there's often an important role for both the clinical ethics consultant as well as the primary care team to play a role in supporting surrogate decision makers in helping them understand the substituted judgment standard and tease out a lot of the different emotions and interests at play in any given advanced care issue. And so I think that touches on the last point here in helping surrogate decision makers explore their values and come to a good use of substituted judgment standard. And one other important point when I'm talking about kind of discussing the practical parts of advanced care planning is the idea of advanced care planning over time. And we know that patient preferences are fluid with time and health status. There's a statistic up there from a study of kind of chronic disease patients and how their preferences regarding code status changed within a year. And there's a lot of literature on the subject suggesting that over time and even with changes in, evolution in health status with admission to the hospital versus outpatient, that patients' preferences regarding what they want at the end of life, their treatment, can radically change. And what that means for advanced care is that often we want to see what the most recent statement of preference is. At 20 years old, it's hard for me, and we can kind of intuitively understand this, it's hard for me to say what I would want at 60, but at 55, presumably I have a better idea. And I think that's an important piece of this as well, that is when we have advanced care planning, we want to see recency as well as kind of detail and understanding of the condition. So I've talked a little bit about the bioethics and the practical aspects of advanced care planning. So when we finally put pen to paper, what does advanced care planning look like? And traditionally, when we think of advanced care planning, we think of written advanced care plans. And here listed are a few. As I mentioned before, durable power of attorney for healthcare. It's a document in which a patient names a patient advocate who can act as a surrogate decision maker on their behalf. There is also a new form called, in Michigan it's called the POST, Physician Order for Scope of Treatment. In other states it's called POLST, Physician Order for Life-Sustaining Treatment, or MOLST, Medical Order for Life-Sustaining Treatment. And I'll touch a little bit about that because it's fairly new, and in Michigan it's only been rolled out in a few communities, and it's still very much being tested and studied. There's also the Living Will, a kind of more free-form document where patients can detail their preferences regarding treatment and their values. There's also, of course, something as simple as code status, whether a patient would want aggressive resuscitation at the end of their life. And finally, tying back into law, states oftentimes have default surrogates or hierarchy of surrogates of highest priority, where if a patient is not named a surrogate, then the default assumption is the surrogate is oftentimes the next of kin. Again, this can also vary state to state. So I'll start with a little bit about POST, because that's, again, as I mentioned, it's a fairly new form of advanced care planning come about in the last few years. It stands for, as I mentioned, Physician Order for Scope of Treatment. What it is, POLST, or MOLST, however you may have heard it, it's a medical order that can be entered into a patient's chart reflecting their preferences for end-of-life care. And specifically, it's meant especially for use in patients who have a very limited prognosis and who tend to be in nursing facilities or nursing homes. And it's still being studied. One initial study that was very hopeful found that patients who had completed a POLST were more likely to have an out-of-hospital death than those who had completed other more traditional forms of advanced directive. So just to peruse, I put a sample POLST form here. There's 3 sections. One addresses code status. One goes into a little more detail on medical interventions. And the final is about artificially administered nutrition. And so I also wanted to touch on some of the shortcomings with POST. And one, of course, is the precondition for completion. Patients, to be eligible to complete a POST, patients have to have a diagnosed prognosis, have to have 2 doctors tell them they have a prognosis of less than 12 months. The other issue that can often arise with these orders is that they're only advisory in the hospital setting. They're only binding as an order in nursing facilities. So that can also often run into issues when patients are approaching the end of life in hospital facilities, though they can still serve an important role in letting us know what the patient would have wanted at the end of life. And finally, and I'm going to touch on these a little later as well, there are some other problems inherent to written forms of advanced care planning. As you saw in the documents, it's fairly limited in scope and in detail, and there can often be, with written advanced care plans, ambiguous language and uncertainty about what a patient would have wanted when they check a certain box or when they initial by a certain line. And also, of course, an issue with written forms of advanced care planning is execution requirements, requirements that patients have to go through, either witnessing or signatures, to ensure that that form becomes legally valid in that state. And 13% of nursing home residents in California who completed one of these had the document rendered invalid due to execution requirements. And what that means is that they completed the document, but either due to failure to sign the document or failure to find a witness, the document was not entered into the medical record and was not considered legally valid. And I bring these up because I think that's a quick preview of what I want to talk about a little later, is that when we talk about these forms of advanced care planning, there can often be shortcomings, even though they are, as I've said, very powerful tools to help us at the end of life. I want to take a moment here to touch on Michigan state law. As I mentioned at the beginning of the talk, what is considered a valid form of advanced care plan can often vary state to state. In the state of Michigan, the durable power of attorney for health care is the only legally recognized form of advanced directive. And again, the durable power of attorney for health care document names a patient advocate that can make decisions for the patient in the case that a patient has lost decision-making capacity. Just a few quick things on the DPOA. The patient advocate named there can make decisions regarding mental health, even if the advocate has not made even if the patient has not made that specifically, explicitly clear. Another interesting point is that these can be revoked orally at any time, even if the patient is determined to lack medical decision-making capacity. And I want to bring this up because I think it hits on a very crucial point about capacity, which is that capacity is not an all or none phenomenon. when we determine that a patient lacks medical decision-making capacity, oftentimes they can still retain capacity to make other decisions. And it's important to realize that capacity more often comes in gradations than in a specific kind of on-off setting. And finally, another important point, given state-to-state variability, Michigan reciprocally honors advance directives that are considered, that are legally recognized in other states. So for example, in Ohio, living wills are legally recognized as forms of advance directive, and if a patient was to cross state lines, it would be recognized in the state of Michigan as well. I also want to pause here to say that not all states have this kind of reciprocity statute on the books. So I've talked a little bit about what written advanced care plans look like and what the state laws around them are. And I want to take a moment to say that these are extremely important and documents, and they should definitely be encouraged for all patients in whom the clinical situation is appropriate. However, there are some shortcomings to these written advanced care plans. I think the foremost one, and the one that many of you may have encountered in your clinical experience, is vague language and unclear references. Oftentimes, living wills in particular will have sample sentences to check off, or a single sentence to demarcate a whole kind of world of patient values and patient understanding and potential treatments. And there's one such quote here from an Arizona living will document, and it says, "If I have a terminal condition, I do not want my life to be prolonged, and I do not want life-sustaining treatment beyond comfort care that would serve only to artificially delay the moment of my death." Now, we can imagine where this would run into some problems. Imagine a patient is at the end of life, and much as the patient in the first case is aspirating, and they develop a pneumonia. Is the administration of antibiotics considered life-sustaining treatment because it would prolong their life, even though that's not, in fact, the condition that would that has caused them to get to this point? And I think, along those lines, there's a lot of uncertainty when we have statements like this that are meant to be general to cover a broad range of possibilities, but oftentimes in practice can leave us unsure as to what specifically we want to do. There's a quote here from Dr. Stephen Miles, a former president of the American Society for Bioethics and the Humanities. And to sum it up, he makes the point that advance directives oftentimes try to encompass this really broad range of ideas, of patient values, of potential treatments that patients might encounter, and potential scenarios, clinical scenarios that patients might be put in. But when we come to advanced care planning, as many of you know, there's a vast, vast world of these scenarios, and there's often conflicting interests, conflicting values, conflicting ideas. And these can't often be contained within a single document, and oftentimes it's very difficult to try and take these documents that are meant to be generalizable and apply them to the specific scenarios that we can find ourselves in. I want to touch on a few other shortcomings. One, of course, is sociocultural inadequacy. And this has been written about in the literature. Oftentimes, the way that we conceptualize surrogate decision makers, and especially even patients when they have medical decision making, are as single decision makers. We place the burden of decision making on a single person to make a final decision. Oftentimes, this doesn't reflect how decisions can traditionally be made in cultures outside of our own, as part of a family unit or as part of a broader community. In addition, and this is something that is also often encountered, we think of the patient as the primary recipient of information. That is, if the patient has the capacity to make medical decisions, they should be fully informed and they should be the ones making the decision. And oftentimes we encounter situations where patients don't want to know information, or the family desires that the patient doesn't have the information, and that the decision-making be shifted even while the patient has decision-making capacity. And I bring this up because a lot of our advanced directives in written forms only come into effect once the patient is determined not to have medical decision-making capacity. And finally, just a few other points here. So one is witnessing requirements. In the state of Michigan, to make a designated power of attorney document legally recognized, it requires 2 witnesses. And there are limitations on who can act as a witness. In the state of Michigan, members of the care team, clinicians, and family cannot act as witnesses to this document. And you can imagine where this could run into issues, especially a patient who's hospitalized and unable to really find anyone, and whose primary point of contact throughout the day is either his care team or his family. There's also, as I mentioned before, significant state-to-state variability in law regarding advanced care and law regarding recognized forms of advanced directives. And there's also incomplete reciprocity. And an important point to make here, especially with state-to-state variability, is not just that certain forms are recognized in certain states and certain forms are not, but that the language itself is very different. So Michigan uses the language of durable power of attorney for healthcare. Other states may have a similar form, but use completely different language and not recognize the durable power of attorney for healthcare language. And so I think it's important to note that this kind of incomplete reciprocity and state-to-state variability takes many forms, and oftentimes when patients cross state boundaries, these can often be extremely confusing. So, with that as a background, I wanted to kind of delve into the updates to the policy here at the University of Michigan. Why do we feel it was necessary to update our advanced directive policy? I think the primary driver here was that the old policy only referenced the durable power of attorney for healthcare as a means of advanced directive. And we wanted to, as I mentioned, kind of recognize that there's a broader scope here and that we have other options available to us beyond just the durable power of attorney, which is, of course, extremely powerful. We wanted to emphasize the team-centered approach to advanced care planning at the University of Michigan. It's not just, it's not just the physicians here. It's the nurses, the social workers, translators. The entire team plays a crucial role in in participating in dynamic end-of-life conversations and in participating in end-of-life care. And we also wanted to clarify the partnership of ethical and legal. As I mentioned, there are state laws regarding what is considered recognized forms of advanced directive. But the ultimate goal of advanced care planning is to provide ethical end-of-life care by recognizing patient autonomy. And so, what exactly is new in the new policy? So I think the largest change is that we wanted to broaden our scope of what we consider legally valid or legally recognized forms of advanced care. We wanted to recognize living wills. This is fairly common for patients to fill out, even with a durable power of attorney for healthcare document, to inform their patient advocate. Oftentimes, this will be a document that patients fill out without a durable power of attorney for healthcare. We also wanted to recognize, and I think this is important, documented clinician-patient interactions. And what that means is that we want to recognize that the conversations that happen between patients and their care team at the end of life can often be extremely informative when we want to make end-of-life decisions. And oftentimes in patients who lack more formal advanced directives, these can be used as very powerful drivers in determining what kind of treatments we want to use at the end of life. We also wanted to clarify ethical and legal language. And I think one important point here is the difference between competence and capacity. Competence being primarily a legal term, and capacity being a more useful clinical term that is determined by doctors on site and that is more useful to us when we're talking about what we consider ethical end-of-life care. And finally, as I mentioned before, emphasizing the team-based nature of advanced care planning. In the new policy, we outline how multiple different departments play a role, including, as I mentioned, social work, nursing, the legal office, the role of the clinical ethics consultant, and the ethics committee, and how all of these players can work together to help patients get the end-of-life care that they desire and that they deserve. So the first thing I wanted to talk about was documented interactions. That's the language that we use in the new policy. And what we want it to mean is conversations between providers or clinicians and patients that are documented into the medical record. And this change was really brought about largely because these are already being used here at the University of Michigan to make clinical decisions at the end of life. And we wanted the policy to reflect that and also to encourage that. We say this because we use the term documented interactions, and I want to remark on this briefly because we wanted to recognize multiple forms of interactions, not just oral ones, but ones that are documented into the patient's chart. Another aspect of this that I wanted to emphasize is that these forms of advanced care planning should be seen as complementary to existing written forms. I've talked a little bit about the shortcomings of written advanced care plans, but I by no means want to use that to mean that these aren't useful or that these aren't powerful tools. Rather, that these tools, powerful as they are, have their shortcomings, and that broadening our scope of what we consider advanced directives and advanced care planning can help us address some of those shortcomings. And so what they can do is they can fill in some information that's missing from written documentation. As I mentioned, oftentimes language can be confusing or unclear, and if we have a documented conversation between a patient and their clinician discussing, for example, the use of antibiotics or the use of a ventilator, this can help us clarify what to do in a given clinical situation. It can also help with the problem of what's commonly called the unbefriended adult, the adult who has no real family, no friends who can really act as surrogate decision makers who are informed about their values, and also oftentimes lack durable power of attorney for healthcare documents and other written forms of advanced care planning. And to give you just a sense of the scope of this, 3 to 4% of older nursing home residents do not or cannot name a surrogate in the state of Michigan. So the unbefriended adult is not a small population, and it's certainly one that we want to consider when we talk about advanced care planning and end-of-life care. And the use of a kind of broader scope to approaching advanced directives can be extremely useful, especially in this population. And finally, I mentioned before sometimes that there's some sociocultural inadequacies with our traditional forms of advanced care planning. And within the confines of a clinician-patient, clinician-family relationship, and with dynamic conversations there, we can often respect cultural norms. The second point that we wanted to clarify in the new policy was the distinction between ethical and legal language. And the primary is competence. So competence is a legal judgment that's often made in court, while decision-making capacity is a clinical one. And as I mentioned, capacity is an extremely useful term, and it's also extremely important to recognize that it is not an on and off switch. Capacity is not there or not there. Capacity applies for different levels of decision-making that require different levels of knowledge and different levels of awareness of the risks and benefits. And I also wanted to touch on patient advocates, the ones who are named in durable power of attorneys, are ultimately the decision makers. They do oftentimes need significant support from the clinical care team and from other members of the staff. The psychological distress of decision making at the end of life can be immense, and it can be difficult for surrogate decision makers to put themselves in the patient's shoes and try and come to a decision. And oftentimes they need not only just information, but just time, support, and just kind words. And that's an important role when we talk about how we can actually practically implement ethical advanced care planning. Finally, of course, the team. This is what we wanted to emphasize in the new policy, that there's an important role for all members of the clinical care team. Oftentimes, the conversations that the patient has with any member of the clinical care team can be useful in understanding what their values are, what their desires are, and what kind of care they would have wanted at the end of life. I wanted to touch on two specifics here. The ethics consultant can often help if there are competing concerns or competing interests, and if there are, oftentimes competing emotions around the patient's wishes for end of life, not just by a patient's family and surrogate, but also by the primary care team, who can often find themselves in a situation of distress if there's a patient that's approaching the end of life. And of course, the legal office is always there to clarify questions regarding Michigan state law. As I mentioned, state law does vary from state to state, so it's often extremely useful to understand the foundation of the law upon which we build the advanced directives. So what are the implications for clinical practice when we talk about advanced directives and this new updated policy? And I think the first question that often comes up is, what happens if there's an older living will or older written document and a newer documented interaction or conversation, but they contradict each other? And this gets back to a few points that I mentioned earlier, including the idea of recency being important in determining patient preference. Of course, when patients do take the time to fill out written advanced care plans and official documentation, they should be encouraged to update it as often as possible because of the legally recognized nature of these documents and because of the importance of these documents. That being said, oftentimes there isn't an update. And when in doubt, we should often treat according to the understanding of the patient's wishes as they were most recently. And what this means is not that we take one and say discard the other. It means that we should have a dynamic conversation with the family, with a person who has been named a durable power of attorney, and discuss with them what we think the patient's wishes are. Ultimately, of course, durable power of attorneys are legally recognized and should be officially accepted. But I take this kind of conflict to be an opportunity for conversation rather than an issue regarding advanced care planning. Finally, I think it's important to remember that living wills, while they are mentioned, as well as durable power of attorney, can be revoked orally. That means that a patient, even if they lack clinical decision-making capacity, can simply state that they no longer wish a person to act as their patient advocate, and that takes effect. It's also important to note when we talk about surrogate distress and the emotions that come up at the end of life, that patient advocates who are named in a durable power of attorney for healthcare document can decline to act on behalf of the patient. And of course, this is not an all-or-nothing phenomenon. If that does happen, there's always room for support of that surrogate and conversations with them about what exactly is going on and what the emotions at play are. Finally, and I think this is important to recognize also, that living wills and other written forms of advanced care planning take effect only after a diagnosis, living wills specifically take effect after the diagnosis of a terminal illness or permanent unconsciousness. And this gets back to a point I was referencing earlier. Oftentimes, written advanced care plans take effect only after the patient is found to lack decision-making capacity or as a terminal diagnosis. But it's important oftentimes, even when a patient has clinical decision-making capacity, to discuss the future and document these interactions in the chart and use them later on as means of making clinical decisions. I also wanted to talk a little bit about ethics in the law. As I mentioned, Michigan state law legally recognizes durable power of attorney for healthcare. Documented interactions, as we outline them in the new policy, are not considered legally binding forms of advanced care plans, but they can be very important parts of ethical medical care. About 16 states in the U.S. recognize oral advance directives, or we've called them documented interactions. Unfortunately, Michigan is not one of them. But I think the important takeaway point here is to distinguish legal from ethical, but let the two work together. Use all the resources we have at our disposal, including written advanced care documents, as well as documented interactions, to make ethical end-of-life care decisions. So I wanted to conclude with some ethical issues that we discussed in the updating of this policy, and also kind of open up the floor for questions and discussions. I think the first kind of question or issue that comes up is, we've put up documented interactions, the spoken word, and we've said these are extremely important and that we should use these for advanced care planning. A quick counter-argument might run that, well, when a patient sits down and takes the time to write out their wishes and, get it legally recognized, isn't that necessarily, showing more interest and more effort and therefore more reflective of true values than simply a conversation had in the clinical care office? And I think this is an important distinction to make, and I think the primary thing here is also to look at, do these written forms commonly reflect patient desire as it's measured? And there have been a few studies on this looking at living wills compared to patients' desires a few years after that. And there's a couple important points. One is that living wills and other forms of documentation are often completed in the outpatient setting. And as I mentioned earlier, patient preference around end-of-life care and end-of-life treatment can change radically upon hospitalization and upon evolution of their illness. I think the other important point here is that the studies that I mentioned show that living wills alone only moderately correlate with patients' wishes stated, about a year or so later. And I think it's important, again, to talk about the importance of the flux of preferences over time, and that patients' ideas about end-of-life care and end-of-life treatment can often change, oftentimes very radically over time. And it's important to realize that, again, the importance of recency and the importance of conversations that may have been had closer to the kind of medical state that they're in now, and with more information about what kind of treatments they may expect coming down the road. Another potential issue here is that when we talk about documented interactions, ultimately the person transcribing these is the physician. That is that while durable power of attorney documents and living will documents are written by the patient and using the patient's language, these documented interactions ultimately use the physician's language and are documented by the physician. And the concern here is there a potential for bias? We know that physicians and patients often differ in what they consider a good death or and their values around end-of-life care and end-of-life treatment. And I think this is an important point to recognize, and I think there are benefits to active involvement of clinicians in end-of-life care that kind of outweigh this potential concern. I think the primary benefit here is clarification. Patients oftentimes don't know the full scope of potential treatments, even sometimes don't know what CPR involves. And so it's important for clinicians to inform the patient of all the possible treatments they may encounter at the end of life, all the possible scenarios they may find themselves in. And as professionals who have more experience with this, it's important for us to give the patients that information so that their planning can more reflect the nature of the reality that they may find themselves in. And I think it's also important for physicians and patients to have these conversations, not just to simply kind of record patient values and patient desires, but also to have an honest conversation about values. And, it's oftentimes we try to be objective as clinicians, but it's important, especially at end-of-life care, to try and understand what our values are and what we feel about end of life, and to see if that is really kind of reflecting how we provide care and how we enter information into the record. And I think the final issue that I wanted to discuss was, can these be used in pediatric patients? Traditionally speaking, pediatric patients under the age of 18 are not considered to have decision-making capacity, and that capacity defaults to adults. Of course, as anyone who's worked with children can tell you, there's a wide range of understanding of disease condition, understanding of risks and benefits from newborn to the age of 18. And children can often have insight into their condition and insight into their treatments and the kind of a lifestyle that they would have. And so I think it's important to also use documented interactions in the pediatric population. It's been identified by pediatric patients and their caretakers as important for well-being and planning. And I think also, I want to touch on this well-being point here, that these conversations are not just ways to help us as a clinical care team make ethical care decisions, but oftentimes can help with surrogate distress at the end of life, especially in the pediatric population. Having these conversations and ensuring that that surrogates understand and kind of can get a sense of the course of a disease oftentimes helps in alleviating some of the distress they may face when they're making decisions at the end of a patient's life. I want to touch briefly here on the 5 Wishes document. I mentioned that durable power of attorney for healthcare is the only legally recognized form in the state of Michigan. For children, the 5 Wishes document is considered a legally valid form of surrogate designation. So it can serve the same role as a durable power of attorney for healthcare. Again, the language is different, but I think it's important just to touch on this point briefly. This is what the 5 Wishes document entails. The 5 wishes are who I wish to be my surrogate, what my wish for the kind of medical treatment I want, my wish for how comfortable I want to be, my wish for how I want people to treat me, and my wish for what I want my loved ones to know. And of course, this is all important information. I think the important point to realize here is that the answer to this first wish, the who I wish to be my surrogate, is legally recognized in the state of Michigan. So just to kind of sum up, I've talked a lot about written advanced care plans and again about their shortcomings. And I want to stress again that I'm not trying to say that these are useless or that these shouldn't be encouraged in patients. But the reason that I point out these shortcomings is to point out that there are other paths that we can take to get patient preferences and patient values and use them at the end of life, and that those have been reflected in the updates to the advanced directive policy, especially the part of documented interactions and conversations with the patient. And I think this is important, and again, this is another point, is that these have been integrated into the policy primarily because they reflect existing practice here at the University of Michigan. We're already, from my limited experience, I've already seen clinicians who excel at talking to their patients about end-of-life care, talking about values, and incorporating them. So I think it's important to integrate this into official policy, not just at the institutional level, but also eventually at the state level. And it can help us better understand and respect patient wishes. Just some cited works, and thank you very much.
Kunal, thank you very much. This is great and interesting. One question about the process, the either legally required process or institutionally expected process for declaring patient decisionally incapacitated, and therefore that the DPOA can step in. So now, in my experience here, not much happens around that. We just kind of we got the DPOA in place, and we just kind of say, okay, this patient now no longer possesses decision-making capacity. But is there a documentation process for that? Is there a form? Is there an expectation for declaring that person incompetent so that the durable power can take over?
Sure. So, I'd like to preface this with I have not personally been in any of these situations, so my knowledge of this might be limited. But I think it's the designation of capacity is a clinical one, and it's one that can be made by the primary care team to say, this patient is determined to lack decision-making capacity. Psychiatry can be called in if there's some confusion or if there's some discomfort in evaluating decision-making capacity, but it's not necessary to get a psychiatric consult. Competence, on the other hand, is a legal term, and to have a patient declared incompetent, it does require a legal process, usually involving the family. That's a more detailed process, and I don't have a lot of the details on what that involves. But to kind of get at the first part, to get at capacity, the primary care team can make that designation if they're comfortable.
And it should be clearly documented.
Yes, I'm sorry. Yeah,
they assess that, and that's what their determination is.
The reason I ask is that I recently heard there's a separate form that two physicians should sign. One of my nurse practitioner care navigators is trying to educate me on, like a separate document that goes in the document section that's signed by two physicians that says this is the time the durable power of attorney can be invoked because this person lacks decision-making capacity. Now, documenting in notes, I got it. But
is that for outpatient?
yeah, that's what I'm.
Because I heard before the geriatrics. That
Yeah.
the formally activated verbal medical power of attorney, you have to have two physicians, two clinicians sign a form designating the person who's better with the person having capacity. Of course, in the hospital, we'll walk in the room and say, that person can't make decisions, where's the case? We don't go, I've never signed a piece of paper in the hospital declaring someone.
And is she talking about the do not resuscitate outpatient designation form, which is
No. It's about
okay.
the process necessary to allow the designated durable power of attorney advocate to make decisions on behalf of patients.
I think it's not the difference in practice inpatient, outpatient. Inpatient has a sort of sliding scale of capacity. Someone could have capacity when they are not planning for inpatient or after surgery. So we're using the surrogate in that decision to know and evaluate the patient at the time because that's the decision to say they're unable to make this decision. And then the medical staff can't do that. In the outpatient setting, at home, if someone does have.
It's probably even more true in the outpatient setting where the variety of decisions is in fact broader.
And that's not necessarily evaluated at every decision, right? So once they walk out of their office, is that how do we know they need the durable power attorney for what decisions? All decisions? Yeah.
Well, but it's really the same, and they just have it over a longer period of time. Okay, interesting. Good. I'm sure it hardly ever happens in the outpatient setting. Well, I've just been neglectful for the last 25 years.
She was in a rehab center 2 years ago, and they asked me to have two different physicians sign so I could make a decision for her.
Yeah.
And I've been her DPOA years patient ever since.
Yeah. So maybe something that he should open more.
Something to look at. Again, it was a rehab outpatient.
Yeah.
But no, I personally didn't experience.
Well, and technically under the law to invoke the DPOA, there has to be a physician and a second either psychologist or physician that has to agree. And then that should be done in Chapter 2.
Yeah, well, either one, because I'll bet there's not very often a second physician that comes in, you know, on a primary care setting, who's patients have known for 20 years. I've never gotten a second physician.
I've lived in nursing homes before.
Yeah.
So when someone lives in a nursing home, their physician signs back and then you as their primary care provider also signs forms so that I can make decisions for me.
Right.
That's what I've seen. I haven't seen you.
I was wondering if there would be possible liability issues by recognizing different wills if not recognized legally by the state.
Sure. So I think, of course, if you have any questions about liability, it should go to the legal office. But the okay. So, but I think the policy as it was written was meant to more encompass what we consider kind of ethically recognizable forms of advanced care planning. And it's made clear there, of course, that the only official legally recognized form is the durable power of attorney for healthcare. But it's more of an encouragement to look to all the possible resources that we have to make kind of ethical end-of-life decisions.
I think the other way to address that is that the default answer would be to go to a best interest standard, which is how we would treat someone who was brought in by EMS and hit by a bus. But if we have knowledge of prior state wishes, and that knowledge has been really disseminated and documented, then we are ethically empowered to act upon it, even if it is not legally recognized in the same way. So I think that's the ethical defense for what we're doing. But again, as many things that we do from local utility to many others in the institution, our practice is not necessarily bounded or directed strictly by state law.
I often think of informed consent forms and advanced directives as sort of having the opposite problem, in that we often put too much emphasis on an informed consent form and not enough to the actual conversation that's happening during informed consent. Whereas for advanced directives, anecdotally, I've heard that if the patient is unconscious, almost no matter what they say in the advanced directive, if the family strongly disagrees and the family is there advocating for them, the clinicians will go with what the family is saying as opposed to what is espoused in the advanced directive. And so I was wondering if you could talk a little bit about that tension, perhaps in practice at the University of Michigan, if the family disagrees with what's clearly stated in the advanced directive.
Certainly, and and that's an excellent point. And it's certainly understandable with kind of extreme tension from the family that a clinical care team would feel some pressure. I think this is also an important role for the clinical consultant and the ethics committee. If a clinical care team or primary care team feels like there's competing interests or there's pressure that goes against a patient's documented wishes, there is a role for an outside consultant like the ethics consultant to kind of come in and mediate and discuss with the family and the care team. These are the patient's wishes. Can we discuss why you kind of want this kind of care rather than what's been documented?
Yeah, the classic case here is the patient dying of cancer who says, I don't want aggressive measures, who loses consciousness and what the clinician says what to do. And how do you deal with those situations? So I think the policy here makes clear that the prior stated wishes as documented by a patient would potentially supersede a surrogate decisions unless a situation has changed dramatically. Now, legally, this makes people squirm because we're dealing with a situation in which a legally recognized surrogate is not being honored to make decisions, but only in very selected cases when we have a clear documented interaction of a patient saying something different and the situation not changing dramatically from that prior decision. Again, those are the cases where getting ethics and legal involved quickly is obviously important. But I think before this policy change, UMHS policy was strictly to obey DPOA, HC, and or surrogate's choice, whereas now we're making that a little more nuanced.
And I think that our obligation to follow the wishes of the surrogate are only extended to when we think they're making decisions in the best interest of patients. We have reason to believe that They have some ulterior motive. As in the case that you say, the person says, please don't intubate me, they lapse in unconsciousness. And they say, no, intubate that person. They say, I just talked to him. And he said, don't intubate me. I don't think you're making decisions in the best interest of this patient. We are, I love that term, ethically empowered to say, I don't think you're making decisions in the best interest of the patient. We're going to follow their previously stated wishes of 5 minutes ago. And appropriately so. Thankfully, those are the minority of situations. The vast majority of cases, surrogates do have the best wishes of their loved ones at heart, and we can appropriately trust them to advocate for the patient.
Can you talk at all about when patients' surrogates wouldn't have their best interests? I mean, what kind of situations would lead you to think that's not true? Aside from what you just
I can give you a couple of exciting examples. One not that long ago, when I was involved, this is a couple of years ago, when I was involved with a woman who said, my husband abused our children. I don't care if the advanced directive said, you keep them alive as long as possible, let them suffer. Full code, tube feeds, whatever it takes out, there's a massive stroke. It was very explicit about that, and that was an uncomfortable situation in which we had to say, you're not making, while perhaps understanding the emotionality of where you're coming from, that's not in the best interest of the patient. Other more concrete examples are I'm collecting my mother's Social Security checks. Please don't let her die, and collect that money. Saying again, that's a competing interest.
Or they need money, they need to die so I can collect them in their
Or they are,
exactly. And we've had one or two.
Oh, yes, that's good.
Yeah.
And the more subtle one, in all honesty, is the patient who, where a family member will say, I know my husband would never want aggressive measures in this case, but I can't let him go, and I think we should do it.
Yep.
So when, at that point, the easy answer is to actually just educate the patient that your choice here is not your choice. It's you're acting on behalf of your loved one. So it doesn't necessarily have to be a case of secondary gain like the ones that have just been mentioned, but rather where they're not truly recognizing what substitute judgment needs, just like in all places. Great.
Oh, yes.
In pediatric settings, you mentioned pediatric settings. Would you say that the 5 wishes form is more of an assent, obtaining assent from the patient than, because you still need their parents to consent?
Right. So yes. So as I stated, the 5 wishes document, especially as it pertains to particular treatments, is more of assent rather than consent, which is consent in pediatric populations is obtained from the parents.
It's worth mentioning that there exists a document specifically aimed at adolescents and younger children to get them to, based off the 5 wishes, to engage in the decision making.
We don't have any of those even mentioned in our policy. Or as any of the exhibits, so it's something for the committees, I think, to discuss. Do that.
You can bring up the pediatric side that uses the voicing my choices, which is the one aimed at adolescents.
Yeah, so I think that we should bring that up among committees.
Yes.
I didn't understand completely on that 5 wishes. The first question of this is who I would want as my surrogate.
Mm-hmm.
If a child, a minor, declares someone different than the legal parents of that child, you said that that is upheld in Michigan. Could you talk
Sure.
more about that? I don't understand.
Sure. So these documents are completed with the children and their parents together. To be legally recognized, it has to be with the consent of the decision maker, in this case, their parents.
Thank you.
Any other questions? Right. So I'd like to thank Dr. Schumann, especially all the members of the Ethics Committee, for giving me this opportunity and giving me this opportunity to help out. And thank you all for coming.
Sorry, guys.